Hey guys, Woodruff here. Still alive, still doing these PowerPoints. I feel like I've been here my entire life in this PowerPoint. But that's how it feels when you're stuck inside. It's again, hashtag quarantine days. So here reporting to you live from the Texas 2023. What year is it? This is how bad and far gone I am. 2023 February snowstorm. Here at home, still alive. There's maybe a need for more alcohol in my home, and I should be careful what I say here because they're gonna reject this. What do you call it? For ads on YouTube. So I'm gonna stop now. But this is my I'm not encouraging alcohol in those that are under 21, only if you're old enough to drink it or very desperate. So anyway, um, this is the end, hopefully the last PowerPoint for my diabetes lecture. This is going to be over other treatments for diabetes. We've just got through all of the medications. So we're going to be talking about lifestyle changes, nutrition, exercise, etc., and doing some things to kind of bring it all together. So hopefully if you've survived this long through my other videos that you're still here with me to listen here now. And like I mentioned, I think, let's see, yeah, it's 2:15, so there is still a good chance that my son could interrupt me. So far, so good, knock on wood, but hey, gotten so lucky, so it only takes, once for me to be eternally embarrassed, but, luckily, I really have no shame left because when you have children, it brings you to a place, where you can't have shame because they find ways to get to your soul and offend you and assault you and assault you in ways that you would never imagine. And, again, if you're watching this and you're screening this, if it's appropriate for ads, it may not be, it is actually appropriate for ads. It has nothing to do with this. I'm sharing my personal experience, but, this is reality and also dark humor. If you're a parent, you'll get it. But that has nothing to do with what we're actually talking about today. So moving on, let's talk about first start out talking about diabetes nutritional therapy. So like we've talked about for all the other treatments for diabetes, we are trying to keep a stable glucose, blah, 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 glucose, which effectively leads to less complications. So we can do this through medications, but we're going to talk about this for a lot of things. I don't want to just throw a pill at someone. At the end of the day, I could give them insulin, oral medications if they're type 2, and all these other things. But if they are still eating like crap, it's not going to it's helping. We're chasing something and versus really looking for how we can improve or make something better. So, with that being said, we need a diet that can help with the problem, the fact that they are diabetic. We usually need like a low carb diet, but we also need something like a heart healthy diet because we're trying to prevent complications too. So we want a diet that can provide a stable blood glucose, can decrease their cholesterol, can prevent, in general, like cardiovascular disease and other complications. So we look a lot like the low sodium is what we're also looking for. So usually we're on a low carb heart healthy diet or diabetic heart healthy diet. All right. So the carbohydrates are going to be individualized depending on the patient, but your doctor would go over. I'm talking like I'm talking to the patient. The nurse would, the nurse would, have that. Let me just back this up. The doctor would talk to the patient about what their carbohydrates should be. As a whole, we like their dietary fiber to be increased because it's going to help. So we're definitely looking at having things like more fruits and vegetables on our plate. Want to avoid high cholesterol foods because again, it's all about heart health. We're trying to keep those blood vessels strong. They're already getting all the damage from the extra sugar. We're going to limit saturated and trans fats. Fats are not necessarily unhealthy, but it's just the right kinds of fats. The protein target's going to be individualized as a whole. We want healthy proteins like white meats, and I have a slide next, I believe, that shows what's good, what's bad. But as a whole, we want to individualize that depending on the patient. And then moderate alcohol consumption. So, women get about 1 drink a day, and men can have up to 2. And remembering again that alcohol can cause a low blood glucose because the liver gets overwhelmed and it can't handle the alcohol. And working on the glucose storage and getting those storage things open when alcohol is being processed. So you worry about a low blood glucose in people drinking. So this is not an end all be all. Everyone should, work with a dietitian or otherwise. But here's just some ideas, because especially when we get down into the GI content, students always find it really confusing to figure out what foods are right, or if you get those dietary questions. Here's some good foods. Lean meats are good, like baked chicken, fish. If they do dairy, want it to be low fat when possible. Whole grains, green leafy vegetables, and general veggies, legumes and nuts are good options. Want to avoid anything that's fried, processed, things like butter, cake, sweets, biscuits, red meat, because it's more about the cardiac health than anything. And then we want to avoid things like full fat dairy, like whole milk. So there's what's called carbohydrate counting. And so we've already kind of talked about sliding scale insulin, but what a lot of times we do now in the hospital is what's called, and they do this at home too, it's what's called carbohydrate counting. And that's like where you're meal planning, looking around how many carbohydrates you're going to eat. And you actually give medicine to meet the carbs that you're about to eat. So like I mentioned, carbohydrate needs are individualized, but a general serving of carbohydrates is around 15 grams. And so usually the goal for a plate is going to be about 45 to 60 grams of carbohydrates, or, about 2 to 3 servings. Sorry, 3 to 4 servings. Um, and so, like I mentioned, some sliding scales, what they have, like, so we don't want to just like, like let's say we check someone's blood glucose before they eat and it's like 170 something. We give them something to treat that blood glucose, but they're about to eat too. So there's a lot of sliding scales now that are built with what we call like for carb coverage. And so like the hospital I work at, what they have, last time I checked, I don't do day shift though. So luckily I don't have to deal with a lot of meals. Is that they're going to get, like, if their blood sugar is 170 now, they're going to get treatment for that, but we're also going to prepare for what they're about to eat. So we give them an additional couple units of insulin per how many how many servings of carbohydrates they're going to have, or those 15 grams. So let's do a practice problem that might demonstrate this. So it says a client has orders for sliding scale insulin and carbohydrate coverage. How many units of insulin should the nurse administer based on the following? So they have the sliding scale here to the left. For insulin Lispro coverage, we need to give this, plus we need to give 1 additional unit for every 15 grams of carbohydrates. So their last blood glucose was 215. So I need to do 2 things here. First, I need to see how much do they need based on their blood glucose. Their blood glucose is 215. So if I go over here to my sliding scale, 215 is in here. So they're going to need 5 units there. And then they are going to have 45 grams of carbohydrates. I need to divide so they're already going to have 5 units based on their blood sugar of 215, but they're also about to eat. So I'm trying to cover this and then also prepare for the 45 grams that they're, this should be client 8, 45 grams. So it says here in their orders, they get 1 additional unit for every 15 grams of carbs. So I have to do 45 divided by 15, which should be 3. So they need an additional, it says give 1 unit for every 15 grams. So that means 3 times 1 is going to be an additional 3 units. So they get 5 for their blood sugar 215, and they get an additional 3 units for their 45 grams of carbohydrates. So 5 plus 3 is 8. I don't know why I'm saying that, but I'm getting a little loco now. But they're going to have 8 units of insulin that needs to be given based on this. Hopefully this makes sense. I do have a worksheet on my Google Drive that has a bunch of these problems if you want more practice with it. So now let's talk about exercise. So how does exercise help? Exercise helps to maintain an ideal weight for these patients. Exercise can lower your blood pressure and blood glucose for up to 48 hours after exercise. It decreases the need for so many medications. Again, I mean, the goal is not that they're, on a ton of meds. The goal is maybe we can manage them with less medications. It also helps to lower cholesterol, that gets rid of the bad stuff and increases the good stuff. And it decreases insulin resistance, so the cells are more receptive to letting insulin let glucose in, and it improves circulation. So, what do we need to know about diabetes and exercise? We want to encourage patients to exercise after they eat and to check their blood glucose before they exercise. So I talked about this in a different video earlier about how when someone exercises, a lot of people think, oh, they're stressed out, they're working hard, their blood sugar is going to be up, but it's actually down because I'm using. Remember, sugar and glucose is energy. So, do I need a lot of energy when I'm exercising? The same thing when I'm sick. So, like, well, sorry, no, I said that backwards. Ignore me. Not, oh my God, I don't want to do that analogy because that'll confuse you. But just think about this: is that when people that are diabetic exercise, their blood sugar goes down. And so we need to check it before. So if they check their blood sugar before and their blood sugar is less than 100, is that they are going to need to eat a snack and recheck, but they should not exercise unless their blood sugar goes above 100. If it's at 101, they should still be, be careful. So we want their blood sugar above 100 before they can exercise. But specifically, if they are a type 1 diabetic and if they check their blood glucose before and their blood glucose is greater than 250, they should also, there's like home tests where you can check ketones in your urine. They should check for ketones in their urine. They should drink water and not exercise if their blood sugar is greater than 250 and they have ketones in their urine. But as a whole, remember, high and dry. The higher my blood glucose is, the more likely that I'm going to, get into a state of crisis, especially with type 1 diabetes, like diabetic ketoacidosis. So if my blood sugar is already 250, and then that's going to be dehydrating me at being that high, and then I get on a treadmill and I'm running, that's going to dehydrate me even more. So for these patients, I want them to drink water and to not exercise if their blood sugar is that high. We're going to focus kind of on like the hyperglycemia treatments. These patients should have good footwear because we worry about them breaking down or hurting their feet. And we usually, in general, we don't want them to have any skin breakdown. Think of all the foot complications we talked about earlier. And we recommend at least 30 minutes of moderate intensity aerobic activity, like 5 days a week. So moderate intensity is where you could like be on a treadmill. You shouldn't be able to comfortably have a conversation if you're doing a moderate intensity. So more teaching. Exercise does not need to be intensive to be effective. So these patients, a lot of times you get a diagnosis of diabetes and you're like, oh my God, I got to lose 500 pounds and do all this stuff. It doesn't have to be crazy. Sometimes the best exercise is just walking. Just simple walking around the neighborhood can do a lot of good. We want to choose things that they enjoy because they're going to be more likely to continue and do it if they enjoy it. They should include a warm up and a cool down in their exercise routine. It's going to help to stretch their muscles, prevent injury, and allow that doesn't stress out their body too much. They should monitor for hypoglycemia after their workout. It can happen hours later, so they should definitely keep that in mind, and they should bring snacks with them in case they get hypoglycemic before, during, after exercise. There is alternative treatments for diabetes, that like things that can not necessarily cure it, but can help with it is going to be like bariatric surgery. If we can decrease some of their comorbidities, like their obesity and things like that, it's going to help to achieve better blood glucose control. But these are only going to be helpful if we do them with permanent lifestyle changes. And we'll talk more about bariatric surgery later. But there's no point in doing bariatric surgery. Like it can't 100% fix or cure a person who has bad lifestyle habits. So like a person can't get a bariatric surgery and again continue to eat like crap. They have to start changing their lifestyle because it's all about, as a whole, how we can really start to get ahead of this patient's health. And it's a holistic thing. It can't be just one. There's also islet cell transplants. These are hard. They have to take usually multiple people who have passed away take islet cells from their pancreas, and we transplant them into the liver of the living person, then their liver pretty much is starting to secrete insulin from these islet cells. It can definitely help. It's not a end all be all fix mean, and it's not something I've ever seen done, but it is something that's possible. And then, like I mentioned with my cousin, my cousin had just such severe type 1 diabetes. She was diagnosed in her 30s and she had like multiple crises, comas, was always in the hospital. Ended up being dependent upon her mom and dad, like, up in like, I mean, she's in her 50s and had to like round the clock care, couldn't work, couldn't do anything. She was just incredibly debilitated and she ended up going into end stage renal failure. She was on dialysis for a while. And it was such a hard struggle because like it was like she would get an infection and so they would take her off the transplant list until the infection cleared, and then she would have to go through all this testing to make sure she was ready for it, and then by that time like she would have a short time on and then she would get another infection or another complication would come up. So it was such a hard struggle, but it's definitely worth it. It took her a few years, but she got her kidney pancreas transplant. And she's not cured of the complications that have happened to her body since having diabetes, but she doesn't have to live day to day the way that she was. So she doesn't like for a while. A lot of times, I think she needed dialysis for a while. They can still have some blood sugar issues, but it starts to normalize. They hopefully get back to some semblance of a semi-normal life. So yeah, so like I said, they can still have like all of the complications and stuff when it comes to like if they've already had like teeth problems, eye problems, which I think she had like some blindness or some decreased vision in her eyes, some retinopathy. Those kind of problems, they can still be there, but they're usually not as bad, or we're hopefully moving in a good direction. So it's not a cure, but it definitely can make it a lot better, and it can fix a lot of the glucose regulation issues, obviously. So, what's my role before a patient gets diagnosed with diabetes? Is going to be screening for those that are at risk, knowing those early signs of insulin resistance, such as acanthosis nigricans, which I'll show you on the next page. And then after they're diagnosed, I'm monitoring for acute complications or crisis. I'm monitoring for chronic complications. I'm teaching to prevent those complications or manage them. I'm trying to support their comfort and independence. And then during a crisis, of course, I'm managing them and supporting their hemodynamics or their like blood pressure and their oxygenation, fluid status, everything during that. So let's talk about acanthosis nigricans. So this is what it looks. It might be in the armpits, it might be on the side of the neck, the back of the neck, or the back of the neck. And what it is it's like a darkening or just a different pigmentation of the tissue, and it's a sign of insulin resistance. So usually if you find a patient who has this, it's usually a sign that their cells are starting to resist allowing insulin to bring glucose into the cell. So I actually did I had to do a community service project, like a community health nursing clinical, and I was in a elementary school. And I asked the school nurse, I was like, hey, I got to educate the kids on something. What do you think? And she said like, hey, they actually go now in elementary schools and they document, they screen all the students, they look at all the students and look in their areas where they have folds and look for this. And this is because this is a pre-diabetes sign. And you would be surprised how many of these kids in elementary school already had signs of insulin resistance. And not all of them were obese. So some of it was just genetics, where some people are going to be higher risk. So I did a class for all the students who had acanthosis nigricans, taught them about diet, healthy food choices. And some of these kids were as young as first and second grade. So it can definitely happen very early. So don't just think this is in older patients. So yeah, so it's definitely something to kind of keep an eye out for. If you see this in a patient, it may be a sign they have trouble with their glucose, insulin management. So regular monitoring for complications is going to be key for patients. We've already talked about some of this yearly. They're going to need to get an eye exam to look. We're definitely looking for vision changes. We're looking for retinopathy, things like that, glaucoma, cataracts. We also want to check their kidney function by doing urine testing for albumin, looking for if those proteins are getting let go, and they need yearly checks on their cardiovascular health. Usually we want to keep their goal blood pressure is going to be less than 140/90 in order to trying to prevent some of those cardiovascular complications. We also probably check their cholesterol levels every year because all the plaque issues around sugar and insulin. We're going to do regular hemoglobin A1C checks. They usually get those every 3 to 6 months, and regular teeth cleanings because they're going to be more at risk because the teeth and the heart are closely connected. If you get bacteria in your mouth, it really commonly can spread and cause problems in your heart. So we like to keep everything very clean and well taken care of. On a daily basis, what does a patient need to do for monitoring and prevention? Daily, they should do blood glucose checks. It may vary. Now, you're going to talk to some patients and they're going to be like, oh, I don't even check my blood sugar at home, or I never have to check it. I'm on oral meds. But really, there probably should be some sort of monitoring on a regular basis. Um, Regular skin and foot checks. And remember, if they have a vision issue, someone else may need to look for them. So they shouldn't, if they have the retinopathy, they should not be looking at their own feet. They may not be able to truly see if there's a problem. But if they have good vision, they can do their own self checks. And again, if an injury occurs, they should wash and apply in a non-abrasive ointment and then cover it. And then if it doesn't start to heal or get better within 24 hours, they need to call their doctor. Good hand hygiene, and then they should monitor reporting an infection. So an infection for a patient that has diabetes is always a lot more serious than someone who doesn't. So just kind of keep in mind, like, for example, like a lot of patients, there's a patient that was super young, was young, like 21, had a minor abscess on his lower abdomen, but they admitted him to the hospital for 24 hours and did like a overnight monitoring because he had a new diagnosis of diabetes. So while like they had to put him on IV antibiotics and all this stuff, where normally we'd probably just do some oral antibiotics, you go home right now, but because he was diabetic, he was such high risk for complications. They cannot heal the same. There's also what's called sick day education. So this is when a patient is sick and has diabetes, they need to know how to best take care of themselves. So one of the most important things you can tell them, do not stop taking their insulin when they're sick, even if they're not eating. They should still take it based on, how their blood sugar is doing, but they shouldn't like compensate. Because remember, your blood sugar is going to go up when you're sick. They should check their blood sugar more frequently, like about every 4 hours, and they need to stay hydrated. Because remember, if their blood sugar is more likely to get high, we need to get hydrated because we can get very dehydrated when our blood sugar is high. And like I mentioned before in the video about oral meds is that with the oral meds, some of them they are not going to take if they're sick. So they really need to consider what's going on. Like, so let's say that you have a patient that is taking oral meds, but they're really sick to their stomach. They can't eat anything. I'm not going to sit there and say, well, you got to take this, take it no matter what, deal with it. Like, like that's not going to help them. They're sick. But if they cannot take their oral meds, they may need to reach out to the doctor, go and see their doctor, especially if it's going to be for a few days, because they might need like something different or something in the meantime. Because again, there's some of those oral meds they cannot take unless they're eating. So with the oral meds, it's a little different. It's not that I'm gonna say, hey, keep taking your oral meds even if you're sick, because they might need it when they're sick. But if their oral meds have directions not to take if they're not eating, they may need to contact their doctor or go in and see their doctor to figure out what's next. Because if they can't take it, if they can't take that med, they have a high risk of having a really high blood glucose or going into crisis, but they still can't take that med if they're not eating. So then we're going to also tell them to, if they have 2 consecutive blood sugars that are greater than 300, or if they do that home test for urine ketones and they're moderate or high, they should contact their doctor because they may be going into crisis. So effectively, sick day, we're looking for that elevation or that high blood glucose. Want them to take their insulin, take their oral meds if they're able, if it's appropriate, if they're and if they're able to eat, and if they're, because a lot of them, remember, not all of them, but a lot of them, you have to eat well in order to take them, or take them with the first bite of the meal. So if they can keep it down, then that's great. But otherwise, then they need to come in and see their doctor. A lot of times, again, when diabetic patients get sick, they need more help. They might need more monitoring. It's not like you or me when we get sick and we just need a couple days to recover. General education, compliance is key. Keeping up with their medications and other health. I can talk. Always have medications and snacks on hand. That's going to be your emergency meds for hypoglycemia. We talked about hypoglycemia and exercise, or in general. You never know when your blood sugar may drop, so you want to always have something on hand. We talked about, infection risk is so high, so they need to stay up to date with their immunizations, and they should always know what their blood sugar looks like when it's high and dry. And the classic symptoms plus the dryness or the dehydration, and then the low, that's the hungry, tired, sweaty, and irritable, like cold and clammy. And then keeping up with management of their other cardiovascular problems like high blood pressure, high cholesterol. All right, we made it through the lecture. Woohoo! I survived. I can't believe it. I never thought it was going to end. And don't think that I love teaching, but again, I would much rather be teaching this in person. I do these videos to help all of you because I love you, and I really care about your education. I know that these videos are helpful, but there's some days that I'm like, if I never had to make a video again, but there will be more. Don't worry. And I don't absolutely hate it. I would just much rather be teaching y'all in person. So anyway, top 3 things that you want to teach about all of the following. So, I'm not maybe not gonna go through all of these, but this is a great thing to do. There was so much teaching in diabetes, so just going through and seeing what can you name, because this is a great way, like, kind of like doing a brain dump. Don't have your notes out, but just go through each of these and say, "Is there 3 things that I can think about that I would wanna teach about each of these?" In general. And so this is a great way to see where your gaps are. Because if you go through all of this and be like, "Oh, I got sick day. We just went over that, but I don't remember anything about managing insulin teaching or health maintenance teaching," it's going to help to fill in your gaps. So this is definitely something that's helpful to do. Go through and try to think about things. So like I'll just go through the first one, diabetes and exercise. So I would want to tell them to eat before, check their blood glucose before, and if their blood sugar is less than 100, to have a snack and don't exercise until they do. But there could be other things there too, like wear good fitting shoes, do exercise that you enjoy, etc. That you could go on and on. But this also helps to think about priority teaching, like which of those teachings, because there was a lot for exercise, which of those, if I don't tell them, could lead to the like highest chance of death or complication. So I would say those around don't exercise if your blood sugar is too high or too low are probably some of the most important ones. So next, I have some open-ended questions here. And again, I'm not going to go through all of these, but these are great to do to kind of look, because there's a lot of crises. Maybe I should have crisis. Yeah, crisis time is fine. I was making sure my verbiage there was right. But what do you call them? As a whole, what you want to look at for this is that um, when it comes to crisis and diabetes, asking yourself these questions. You want to know, what are your assessments that you're going to want to do? What are the cues that they have a low blood glucose or a high blood glucose? And then if they do, you have those cues, then what are your interventions that you're going to do to help to meet that need, whether it's high or it's low? So definitely want to go through that. And last but not least, I will do this one with you. And what do you call it? I actually kind of chuckled a little bit to myself because I was like, this is a fun one, maybe a hard one. I was like, I bet I'm not going to remember this. I wanted to get all these done last night and get all this stuff recorded. I'm so glad I didn't start this last night, because it probably wouldn't. I needed this sleep before after making these PowerPoints and then making them into this. But this is a great thing to do. There was a lot of numbers we've learned about, but I've put a bunch of numbers here and we're going to see. Now, these are these numbers. Let's see if you can remember what the meaning is behind these numbers. So let's look at some of these. I'm going to forget some of these, but I'll see if I can pull them together. So 126. So 126, I think, relates to the fasting blood sugar to get a diagnosis of diabetes. If your blood sugar is above 126 for a fasting blood glucose, you can get diagnosed with diabetes. So then we have the number 90. So I'm sitting there, I'm like, I'm trying to think through everything. So 90. So can I phone a friend? So just kidding. Maybe I'm gonna go to 70 next. Oh, 70. Blood glucose less than 70 is going to be considered hypoglycemic. So hopefully that 90 is glaring at me now. I can't look at it. It's trying to get me. So yeah, so hopefully I'll remember by the time we get to it. So 70, blood sugar less than 70 is going to be hypoglycemic. So we have 6.5%. So anytime you see percent, you should think hemoglobin A1C. So 6.5% is what above 6.5% is what you need for a diagnosis of diabetes. All right, so 15. This one actually has 3 things. So first, there is you could look at that you need to eat within 15 minutes of taking insulin aspart or insulin lispro. You could also look for the rule of 15 for hypoglycemia, of the 15 grams of carbs, and wait 15 minutes. And there was another one. Oh, and I'm going to forget it. Something else for 15. I'll see if I can come back and get it. But some of these, again, I'm not a perfect person. I don't have it all memorized. We'll see. 100. So now all these are leaving me. I was like, man, I should have looked this up before. Spent a little time. I'll see if some of these can come. Let me see if there's some I can put. So 250 is definitely going to be what their blood sugar when they are in DKA or HHS, when their blood sugar gets to 250, that's when I'm going to change their fluids from regular saline to something with dextrose in it. 7% is going to be what we want diabetics to people with diabetes to have a hemoglobin A1C of for maintenance. So 6.5 is for diagnosis, 7% or less for maintenance of diabetes. And then 600 is what someone who has HHS or hyperosmolar hyperglycemic syndrome, that is going to be what their blood sugar is usually above for what was I going to say? For them to have a diagnosis of that. So 90 and 100. What could this be? So let's see. Let's go. So this is what I would do if I was studying this. And what I would do is I would start thinking through everything we talked about. So first we talked about diagnosis of diabetes. And so I don't think any of these have to do with the diagnosis of diabetes. After we talked about diagnosis of diabetes, we also went into so we went diagnosis, then we went into complications. And so we talked about a low blood glucose, and we talked about a high blood glucose, then we talked about DKA, and we already think we talked about some of these for DKA and HHS, but I don't think any of these have to do with those. So then we talked about medications, and so there's different medications. Yeah, I don't know. I think I'm gonna get lost. I'm gonna have to go back and find out what the 90 and 100 are. It's gonna drive me nuts, though. I don't want to go through my entire PowerPoint, so I'm probably gonna have to do a short later and tell y'all what the 90 and 100 are. But now part of me just wants to scroll through and find out what they are. Let's see if I can go back and find them real quick. Let's see if I can find 90 and 100. Don't judge me. I do the best that I can. But let's see. Let's go back and find out what the other 15 is. So yeah, see what the other 15 is. So let's see. So let's go back to the beginning where we had all this long PowerPoint. I almost did 50 like D50. So we already talked about the rule of 15. That was one of the 15s. Let's see. I could say 90 well, no, I don't want to say that. No, I don't think it was that. So it's 90 and 100. What were you thinking, Professor Woodruff? What were you thinking? So it doesn't look like it's anything here. I don't think it's anything about diagnosis. The way my mind works late at night, I really shouldn't be making these PowerPoints. And you can shut me off at any point. That's the great thing. You can just turn me off if you are tired of listening to my crazy antics. But let's figure out what the 90 and 100 are. And some of you guys are probably at home and being like, Professor Woodruff, it's just this. But I wish you could come to a portal to this moment in the past and come tell me what it is. So 90 or 100. What would we want for that? Let's see. I don't think it's anything here. So I'm thinking it's going to be something with the meds is what I'm having a feeling. 90 or 100. Because I don't think I wanted to do too much with the meds because some of the times and stuff, they were so varying. So when it comes to 90 or 100, what could you be? So this is what it thinks. So I did this is a good practice. So if you are studying and stuff like that, this is what you do. You see everything you can do with your beautiful brain. And when you can't find it with your beautiful brain, then you go back into your PowerPoints and you find it. So, and I want to find the other 15 as well, but there's a 15 for the rule of 15, and there's the 15 for 15 minutes for aspart. But what could the 190 be? And watch, I won't be able to find it, and this will forever kill me. And destroy my soul. Oh, 90. This is it. 90-degree angle for how you inject insulin. I got one. So 90-degree angle. I don't know why I had to make that so hard. So 90-degree angle. So now I just need to figure out 100. And if I can figure out what the other rule of 15 is, so 90-degree angle. Got it. Haha. Tried to trick me. I tried to trick myself, and I did. Anyway, I'm gonna stop laughing at myself because I may or may not be semi-psychotic at this point. So 100. What could 100 be? So, because I don't feel like there's a lot with the oral meds. The 100 might have to be forever. What do you call it? Forever a mystery. Oh yeah, maybe that's the other thing. So this is the other 15. So there's 15, the rule of 15 for hypoglycemia, 15 minutes to take insulin aspart or Lispro, and then 15 carbs, 15 grams of carbs per serving for your carb counting. That was the other 15. So what could 100 be? Oh, that's it. I found it. Yay. It's high. It's for you want your blood glucose at least to be 100 if you're going to exercise. And then also the 250 again if you're type 1 diabetic. So I finally found it. So sorry it took me so long and I'm so crazy, but it is life. And hopefully I'm making you laugh along your uh torrential journey through nursing school. So it's not all bad. There's good stuff on the other side, but this is something great to do. Just take out some numbers and drive yourself nuts trying to find them all. Anyway, I hope you enjoyed this icy lecture. Hope they didn't feel too icy, even though it's very cold outside here in Texas. I hope you enjoyed it. See you for the next one.